The next talk really is going to focus on hypertrophic cardiomyopathy and inherited variants. So this will be really all about familial disease in 30 minutes, 29 minutes. So 3 objectives here. I want to talk a bit about pathophysiology, diagnosis, risk stratification, and management of hypertrophic cardiomyopathy. It's going to be a quick survey because it's a short talk. Define the etiologies of familial dilated cardiomyopathy and the role of genetic testing, and we'll talk finally a little bit about this entity of non-compaction, which also occasionally is a topic on the boards. So this is a patient with hypertrophic cardiomyopathy and the typical systolic anterior motion of the mitral valve resulting in dynamic left ventricular outflow tract obstruction. In general, patients with hypertrophic cardiomyopathy present with unexplained hypertrophy that is distinguished from physiologic hypertrophy in the setting of a stimulus, such as high afterload or from valvular heart disease or hypertension. The pathologic hallmarks are myocyte disarray and fibrosis, as shown on the slide. You can see the HCM patient here with this myocyte disarray in comparison to the normal myocardium. Most patients live a full life, but there are serious outcomes in some that really underscore the importance of making the diagnosis. And in particular, we worry about sudden death because this is the most common cause of sudden death, for example, in young athletes. Heart failure is also an outcome in some of these patients who go on to develop towards the end stage of the disease, either very stiff hearts and restrictive phenotypes or even dilated cardiomyopathy. And the prevalence is about 1 in 500 or about 600,000 prevalent cases in the United States. I think one of the messages, and this is a slide from Steve Amman about hypertrophic cardiomyopathy, is that not all patients look alike. There are some who have only mild increases in wall thickness. There are some who have a predominant septal hypertrophy, others with a more convex, and this is basal septal hypertrophy, and this is more diffuse septal hypertrophy. Some with hypertrophy focused in the posterolateral wall, others with more apical variant disease. But all of these are variants of cardiomyopathy and reflect hypertrophy without a physiologic stimulus. The big distinction is in patients who have obstruction and those who don't in the LV outflow tract. About 30% of patients have LV outflow tract obstruction at rest, and another 30% can have provoked outflow tract obstruction with ventricular shrinkage during exercise. This is in general a genetic disorder, and it's a disease of the sarcomere due to a number of described or defective gene mutations within sarcomeric proteins, including beta-myosin heavy chain, myosin light chain, troponins, actin, and myosin-binding protein C. On the whole, about 50% of the mutations are in myosin-binding protein C, another 30% in the myosin heavy chain, and then a smattering of troponin mutations and mutations in myosin light chain and actin and other disorders. In general, we need to think broadly when you see a patient with unexplained hypertrophy about the differential diagnosis. Not all of it, of course, is HCM. Think about physiologic hypertrophy, and it's difficult to make this diagnosis in the setting of uncontrolled hypertension, for example, and one would say that the default there is that it is physiologic hypertrophy. Hypertrophic cardiomyopathy is in there, but renal failure over time, and particularly in the setting of hypertension, might result in significant increase in hypertrophy. Infiltrative diseases we've already talked about. Storage diseases, including HCM mimics like PRKAG2 mutations and LAMP2 mutations, may result in cardiomyopathy. We've talked about Fabry's disease, and Friedreich's ataxia occasionally gives you a hypertrophic phenotype. The other big differential is really between physiologic hypertrophy due to training and non-physiologic hypertrophy due to a sarcomeric mutation. And in general, these are some clues to differentiate the athletic heart from the hypertrophic heart. The pattern of LVH is not symmetric. That's a clue to HCM. The ventricular chamber dimensions are reduced because of the hypertrophy. That is, there's no eccentric remodeling. If there's marked atrial abnormalities, so there's change in chamber size other than the ventricle, the ECG looks bizarre, and particularly look at the T waves. There's abnormal diastolic function or LV filling, and women tend to, with unexplained hypertrophy, these are patients that are much more likely to have pathologic hypertrophy in HCM. The athletic heart generally has a large chamber dimension, not a small chamber dimension, because there's eccentric remodeling. If patients de-escalate training, then generally the hypertrophy goes away, although that doesn't always happen. If patients have supernormal exercise capacity and are vigorously training, then that's a circumstance where you do it. People who are weekend warriors tend not to get that phenotype. And then on MRI, if you don't see late gadolinium enhancement or any perfusion defects, that also might suggest the athletic heart. These are not perfect, but these at least give you some ideas of how to differentiate the two entities. The management of HCM really focuses around three components. The first is control of symptoms. The second is sudden cardiac death risk stratification. And the third is counseling and family screening. And I'll thank Carolyn Ho for providing some of these slides for me. The first issue is really focusing on symptom control. And in general, when we think about hypertrophic cardiomyopathy, particularly in the setting of obstruction, if there are no symptoms, there's no therapy that's indicated. There's a lot of temptation in patients with high left ventricular outflow tract gradients to treat the gradient. But in the absence of symptoms, there's really no data that treating the gradient does anything to alter the natural history of the disease. So no symptoms in HCM, no therapy. Once we have symptoms, then the question is, what's the mechanism of the symptoms, and is it related to obstruction or not? In general, symptoms in HCM are related to one of two causes, either obstruction due to systolic anterior motion of the mitral valve, and it's the anterior mitral leaflet striking up against the septum, obstructing LV outflow, or to mitral regurgitation. And then many patients with HCM have abnormal diastolic filling, and that may contribute to elevation in left atrial pressure with exercise and accordingly shortness of breath. So these are all the ways in which obstruction may contribute to symptoms, and then ischemia can perpetuate diastolic filling abnormalities, as I mentioned. So here's a case, a 64-year-old woman with hypertension who comes in for new onset of dyspnea. She has New York Heart Association Class 2 symptoms on mild exertion. Her blood pressure is 118/70 and her heart rate 64. She's taking amlodipine 10 milligrams daily, metoprolol 25 milligrams twice daily, aspirin 325 milligrams daily. An echo reveals HCM, septal thickness of 22 millimeters with systolic anterior motion of the mitral valve, moderate MR, left ventricular outflow tract gradient of 50 at rest, increasing to 80 with the Valsalva maneuver. So which of the following would you recommend as the first step? Would you A, discontinue amlodipine, B, increase the metoprolol, C, refer for septal myectomy, or D, refer for an alcohol septal ablation? Please vote. Good, so about half of you got the intended correct answer, which is discontinue the amlodipine. The other answers are not wrong, it's just this is always about what's the best answer. And let me talk a little bit about this. Left ventricular outflow tract obstruction, and again, thanks to Steve for these beautiful pictures. Obstruction is worse in general if you have a dynamic obstruction of the LV outflow tract, if there's more contractility. If you decrease afterload, there's nothing, the afterload sort of helps stent open the left ventricular outflow tract, so if you vasodilate, there's nothing to keep the outflow tract open and it collapses. If you decrease preload, the ventricle gets smaller, which brings the anterior leaflet closer to the septum and you get more obstruction. And all of these occur with physical exertion, which is why many people with HCM and dynamic LVOT obstruction are worse with exercise and activity. So in general, to decrease obstruction, you need to avoid things that increase contractility and further squeeze the outflow tract, avoid things that decrease systemic vascular resistance, and avoid things that overly reduce preload, and do the opposite. Decrease contractility, increase resistance, and increase volume. And we have meds that do these things, and meds that do things we don't want to happen in HCM. So in general, if there's no obstruction in HCM, medical therapy is really about giving diuretics for congestion if it's there. And beta blockers and calcium channel blockers may offer some benefits if there is, for example, atrial fibrillation to slow heart rate, or if there is significant diastolic filling abnormality. If patients have refractory symptoms in the absence of obstruction, there are really limited options that really involve referral for advanced therapies and cardiac transplantation. These patients are particularly challenging to manage since with small ventricles, they may not be candidates for routine bridge to transplant with currently available mechanical devices. If patients have obstruction, there's a more deliberate pathway that's available. In general, we can encourage correction of exacerbating factors like volume depletion, encourage hydration with exercise, eliminate vasodilators, and avoid drugs like ARBs, ACE inhibitors, nitrates, dihydropyridine calcium channel blockers like amlodipine in the example I gave you, or phosphodiesterase 5 inhibitors like sildenafil. You can, in these patients, give negative inotropes to help reduce the outflow tract obstruction, beta blockers, calcium channel blockers, and a special drug, disopyramide, that I'll get into a little more detail with in the next slide. Be careful with overdiuresing these patients because you may decrease the ventricular size and exacerbate the obstruction and precipitate exertional lightheadedness or syncope. So disopyramide is a drug that not all of us use commonly. It's a class 1 antiarrhythmic drug that was previously used for treatment of atrial fibrillation, but here is leveraged for its potent negative inotropic effects. The drug improves the gradient exercise tolerance and New York Heart Association class in patients with HCM and obstruction by decreasing LV outflow tract obstruction. And you really don't have it doesn't really have a role in patients with HCM that don't have obstruction. It's typically used because of the potential for organizing atrial fibrillation and promoting one-to-one conduction to the ventricle in combination with a beta blocker or calcium channel blocker like many class 1 antiarrhythmics. And in general, it's contraindicated in patients with decreased EF. Anticholinergic side effects are the primary dose-limiting toxicities and can be treated in part with cholinergic agonists like mestinon. The drug is renally cleared, and there are important interactions with macrolides to consider. And there really is, in HCM patients, not a lot of proarrhythmic effect. This drug is particularly valuable for patients with HCM and atrial arrhythmias because you may get the dual effect of stabilization of atrial arrhythmias and reduction in LVOT obstruction in HCM. The dose is given on the slide here, 150 to 300 milligrams of the sustained release twice daily. So if we then think about patients who don't respond to medical therapy, and typically this is step therapy with either a beta blocker or a calcium channel blocker, typically not a dihydropyridine calcium channel blocker, then the addition of disopyramide on top of that, and then if one fails, then the options really are septal reduction, which comes in the flavor of either myomectomy or alcohol septal ablation, and these are two schematics from a review by Rick Nishimura in 2004. So septal myectomy is obviously carving the septum out, whereas alcohol septal ablation is finding an appropriate septal perforator and then carefully injecting alcohol to induce an infarct in the portion of the septum that's contributing to the obstruction. So in terms of choosing patient myomectomy versus septal ablation, overall, the meta-analyses suggest there are not significant differences in mortality or functional class between the two approaches. However, the post-procedure gradients and the need for repeat procedures is a lot less with surgical myomectomy. You simply get a much more reliable relief of obstruction with surgical intervention, and this is largely because it's done under direct visualization and is not as vulnerable to the caprice of the coronary anatomy, right? In general, the other issue is the risk for permanent pacing, which exists with both. If you do a deep myectomy, there is a risk of pacing, but that risk is considerably lower than the risk that comes with alcohol septal ablation, which may be as much as 20%. The bundle branch block that people develop after procedures also differs. We also don't have a lot of long-term data about outcomes of ablation, but there is the perception that patients come back with greater frequency because the injury is less durable and predictable. And so in general, the ACC/AHA guidelines think through the selection of patients for myectomy or ablation this way. If you have persistent symptoms in the setting of LVOT obstruction, you should get medical therapy. If medical therapy fails, you may be a candidate for invasive therapy. If patients are acceptable surgical candidates and felt to be at low surgical risk, Surgical myectomy is preferred to alcohol ablation, although patient preference and technical factors, or if there's uncertainty about the contribution of obstruction to symptoms, alcohol ablation has a Class 2B indication here. If patients are not acceptable surgical candidates, but they are acceptable for alcohol ablation, that means they have suitable anatomy, including the appropriate septal perforators, they can be referred for alcohol ablation, and that then has a higher level indication because these are not surgical candidates. And pacing, which creates dysynchrony and may divorce then the septum from the anterior mitral leaflet, has been explored as a therapy for HCM and obstruction. It's not typically recommended because it doesn't work so well reliably, but it is a Class 2B indication in patients who have failed other approaches, who have symptomatic and refractory symptoms in the setting of LVOT obstruction. So defibrillator implantation is appropriate for which of the following in HCM? A, syncope during a blood draw 10 days ago. B, LVOT gradient of more than 90. C, a maximal LV wall thickness of more than 30. Or D, late gadolinium enhancement containing more than 5% of the LV mass on cardiac MRI. Please vote. Good. So just to talk a bit more about granular sudden death risk stratification, these are the established in blue risk factors for sudden death in patients with hypertrophic cardiomyopathy. One of them was the severity of LVH. Massive LVH, as you saw in that slide, more than that case, more than 30 millimeters, is a risk factor for sudden death and should prompt consideration of a defibrillator. Patients with a family history of sudden death in the setting of clear HCM are at high risk. Patients with HCM and unexplained syncope, patients with non-sustained ventricular tachycardia at rest or with exercise, and patients with a hypotensive response are at risk. This risk factor, which is present in a lot of patients with exertion who are older, is a less sensitive marker for sudden death than some of the others. But we can amplify our risk stratification for sudden death with other things. Patients with significant fibrosis or scar based on MRI assessment, like late gadolinium enhancement, may be at higher risk. So if you have intermediate risk patients who don't have classic risk factors, you might push the decision one way or the other if there's a large amount of scar on MRI-based assessment. Genetic factors can influence your risk for sudden death, although there isn't a clear association, except in very rarefied circumstances, between the type of mutation you have and the risk for sudden death. So in general, if you have a prior cardiac arrest or sustained VT or unexplained syncope, a defibrillator is recommended. That's secondary prevention. And in primary prevention, if you have a wall thickness that's more than 30 or recent unexplained syncope, then an ICD is reasonable. And if there's non-sustained VT or an abnormal blood pressure response, that's when we look at these other risk modifiers that are some of which are listed on the slide: young age, more opportunity for sudden death, maximal wall thickness that's not quite 30 but getting there, significant LVOT obstruction, a previous septal ablation, remote syncope. If you have those modifiers, then maybe a defibrillator is appropriate, and that's where MRI risk stratification and late gadolinium enhancement become most useful. If you don't have any of those features, then probably shouldn't get a defibrillator. Finally, the third component of this is really the counseling or family screening aspects, and because remember that genetic screening in general is not for the patient because it doesn't influence therapy, but it does influence the surveillance of family members. Screening in adolescence or any consideration of athletics every 12 to 18 months is appropriate for family members of patients with HCM, and for adults who are not contemplating competitive athletics every 5 years. And there is genetic testing possible in probands, which can then lead to confirmatory testing in family members. The issues with genetic testing are that although a number of mutations have been identified, some of which are known to be pathophysiologic, there are a whole host of sarcomere mutations which are of lesser clear significance. So the possible outcomes of genetic testing are that you get a negative test, in which case there may still be familial disease and clinical family members are screened then by clinical criteria, or you get a positive test in which case you can do confirmatory testing in family members. But equally common is this dreaded, for Princess Bride fans, variant of unknown significance, in which there is really uncertainty about what you should do, and there again, clinical screening of family members is probably what's most appropriate. And in general, the likelihood of disease is greatest, or the utility of genetic testing is greatest the more definitive and the mutation is in association with pathogenic entities. Sorry, got a little ahead of myself here. So the exercise guidelines in patients with HCM are important. These are the summary from Task Force 8 of the Bethesda guidelines. I don't show you this so that you can read it, but if you want granular exercise indications, it's a nice reference document. The trouble is that very few patients do curling or cricket. So it's not often practically useful, and I think some of the general guidelines in practice are that patients with HCM can do moderate recreational activity that is at a conversational pace. They should avoid competitive athletics, avoid sprint or burst activity, and avoid heavy isometric exercise. I think for the boards, though, intense physical activity is proscribed in patients with genetic HCM, sarcomeric HCM. So which of the following is true regarding genetic testing in patients with dilated cardiomyopathy? 1, genetic testing has an important role in the prognostic assessment of most DCM patients. 2, a negative genetic test in the index patient excludes familial cardiomyopathy. 3, DCM patients with mutations in troponin T are less likely to respond to standard medical therapies. D, the best potential use of genetic testing is in family screening algorithms. Please vote. Good. So that's the intended answer is D, which is the best potential use is in family screening algorithms, and that's generally true of genetic testing. I think it's rarely for the patient. We aren't yet at the point where it influences our testing of an individual or our treatment of an individual. And it's not good enough that we can exclude disease in the presence of a negative test because there are a number of unidentified mutations or variants of unknown significance. So in general, it's useful because when it's positive, we can screen family members. So what are the genetic causes of dilated cardiomyopathy? Well, with advancing research, there are about 60 different loci and genes that have been associated in some measure with dilated cardiomyopathy, and these span the gamut from sarcomere proteins to nuclear envelope proteins like lamin to cytoskeletal proteins. Especially if we include in our gene panels large genes and cytoskeletal proteins like titin, gene mutations are identifiable in about 40% of patients with familial DCM, which is why we say up to 40% of idiopathic DCM may actually be inherited. When we think about familial dilated cardiomyopathy variants, most of them are autosomal dominant inheritance. There is a subset that have autosomal recessive in patterns of DCM. This is about 16% of the total of familial DCM. Most of these have younger age at onset and more rapid progression to death or transplant. And there's a subvariant of X-linked dilated cardiomyopathy that is maternal, inherited through the mother, where females are carriers and males are affected with severe progressive heart failure, and these are often related to dystrophin mutations. These are the muscular dystrophies, which we'll talk about briefly. The patterns that I like to think about are with or DCM with or without conduction system disease and with or without skeletal myopathy. So if we think about DCM without conduction system disease, this is the most common phenotype. We see a lot of patients with dilated cardiomyopathy and no AV block or bundle branch block. Mutations in sarcomere proteins account for about 30% of these. Different mutations in these same genes may give you a hypertrophic phenotype as opposed to a dilated phenotype, so the specific mutation is relevant. And in this disorder, titin mutations are the most common. Titin is a key structural protein that's responsible for sarcomeric force generation. Mutations in titin are present in about 20% of idiopathic DCM, with a higher prevalence where there is a familial pattern. But the problem is that some titin mutations are detectable in about 2 to 3% of phenotypically normal people, so that means the penetrance is incomplete. Men with titin mutations carry worse prognosis than women with titin mutations. When dilated cardiomyopathy presents with conduction system disease, there are a few more stereotyped entities, and the paradigmatic entity here is the lamin mutation, lamin A. Lamin A and C are nuclear envelope proteins that are mutated in Emery-Dreifuss muscular dystrophy and also Hutchinson-Gilford progeria. They account for about 88% of dilated cardiomyopathy, and there is dilated cardiomyopathy that is anticipated by AV block and atrial arrhythmias. So the sequence is often young onset of atrial arrhythmias and or AV block, and then later onset of left ventricular dysfunction, and that pattern should suggest to you a lamin mutation. There are also some patients with this phenotype of dilated cardiomyopathy and conduction disease that have SCN5A mutations. You'll remember this is the protein that's mutated in Brugada syndrome or in long QT3. Lamin mutations have this stereotyped history that I would keep in mind as you study early onset of AV block and atrial arrhythmias, progressing to ventricular enlargement and the development of heart failure that is often characterized by a high burden of electrical instability and ventricular arrhythmias. So another few dilated phenotypes in the last few minutes here. When we think about X-linked inheritance of dilated cardiomyopathy, think about dystrophin mutations. Here there are two paradigmatic types of muscular dystrophy. The more severe type is Duchenne muscular dystrophy in patients with skeletal muscle weakness, particularly proximal weakness. The patient that has trouble, for example, sitting up from a seated position without using their arms. In association with dilated cardiomyopathy, supraventricular tachycardia is an AV nodal disease. On pathology, there's extensive fibrosis of the posterobasal LV wall, and that results in tall right precordial R waves with deep Q waves in 1L and V5, V6, the lateral LV leads. In Becker's muscular dystrophy, there's a milder phenotype, lesser skeletal symptoms, but often these patients have more prominent cardiac involvement, and isolated cardiac involvement is possible. These patients may also progress to biventricular failure with disproportionate RV involvement. Infranodal conduction abnormalities and heart block is more commonly seen as opposed to AV block in Duchenne muscular dystrophy. There's also a mitochondrial cardiomyopathy that often is heralded in patients who have cardiomyopathy in the setting of other manifestations, dysmorphic facies, sensory neural hearing loss, and these are the ones which on biopsy are associated with ragged red fibers, so think the Murph syndrome, MERRF. A final genetic entity, we think largely genetic entity, is this issue of left ventricular non-compaction with the classic picture shown from Steve Ahman on the slide. This may be inherited, may not be, but there's not enough screening efficiency with genetic testing to recommend routine testing. But patients who have this phenotype, which is a congenital phenotype in which this myocardium is unpacked in this sort of spongiform pattern that leads to heavy trabeculation of the left and right ventricle. These patients may progress on, but in unpredictable fashion, towards progressive LV dilation, heart failure, and may be at higher risk for sudden death. If you have this phenotype, the general recommendation is not to participate in competitive athletics. In general, if systolic function is normal, then there's the thought that there's lesser risk for sudden death. In patients who have poor systolic function, there's greater risk. And in general, any patient with non-compaction has a class 2B indication for a defibrillator, but in general, it probably makes sense to fine-tune that to patients who have a family history of sudden death in association with cardiomyopathy, a low EF, some evidence of non-sustained VT such that the substrate is more severe than just the fact of non-compaction. Coumadin is considered for patients who have low EF less than 35%, and other heart failure medicines are indicated as per guidelines. So I'll close there and take any questions, or do we do that later? Okay, great, thanks.